I want to share with you which is some advantage I think we can take from the soft tissue management we are used to doing in mucogingival therapy and apply them, this concept, the same concept, to the treatment of vertically bony defect. In this vertically bony defect, if you look at as it is, you see that once the tissue that is filling the intrabony component is removed, because it must be removed in order to see very, very well the root and to make root planing intrasurgically in a perfect way, because root planing is necessary to be done, since we did not do before the surgery. It's necessary to be done intrasurgically in order to expose the healthy dentin. Healthy dentin is the dentin that is hard, smooth, clean, with the dentin tubuli, which are exposed to the oral cavity. And so you don't only have to make root planing intrasurgically, but you have also to apply ADTA, gel, 24%, for 2 minutes in order to get rid of all smart layer which is accumulating inside the dentin tubuli. Now, everything is ready to be closed. But you know that whatever type of papilla preservation you will use, the tissue that is closing here, has the tendency to collapse inside the defect. That's because there is no more here the granulation tissue, the tissue that was filling the intrabony component of the defect, which allows my papilla to be perfectly in position, as we saw this morning. So once upon a time, we asked bone filler material or whatever type of, let's say, regenerative material, membranes, bone substitutes, to do what? To sustain the suprabony connective tissue and prevent it to collapse inside the intrabony component of the defect, especially in those situations in which the defect was one wall, like this. You see that there is no buccal and palatal wall, and it's very wide. So it's very, very unpredictable defect to heal. And so we asked the biofiller material or the membranes to sustain the soft tissue defect that is used to close and to isolate the blood clot from the oral cavity. And you can understand that this biomaterial, it's something that jeopardize the blood supply to the supracrestal soft tissue that is used to close. And so the main reason why this soft tissue that was used to close open is because it does not receive enough blood supply because of the interference of the bone filler materials. This was especially true once membranes were used, that membranes isolate the defect, gives the defect back the walls, but separate completely the area of the blood clot from the area that is going to close and to isolate it from the oral cavity. So the reason of the failure was, in my opinion, most of the time, the use of these materials that we ask too much. Not only to be osteoconductive, means to improve the stability of the blood clot, but also to sustain the soft tissue in the right position. So whatever type of papilla preservation approach you want to use, and you know that in the literature, many types of papilla preservation has been described. One of these is made by a palatal incision, and the whole tissue is turned in the buccal aspect and elevated with the buccal flap, and this is called papilla preservation procedure that was introduced by Takei. or the opposite. You can make an incision at the buccal aspect, and the whole tissue is turned towards the palatal aspect and elevate with the palatal aspect, and this is called modified papilla preservation procedure and was introduced by Cortellini. Or once there is no bone at the buccal or at the palatal aspect, you can split your supracrestal soft tissue in two ways. You will see this in more details, with one split thickness papilla at the buccal aspect, which is elevated in the buccal flap, and the whole suprabony connective tissue is turned and elevated full thickness with the palatal flap, and then everything goes back, and the surgical papilla that belongs to the buccal flap is closed against the connective tissue of the supracrestal connective tissue in the original position, and this is called simplified papilla preservation approach. Or there is also an approach which is limited to the area where there is no isthmus, so there is no continuity between the buccal and the palatal flap, where you can increase the dimension of the papilla by making submarginal incision at the level of the two adjacent teeth, so you have a longer papilla that, since is longer, thanks to the coronal advancement of the flap, can reach the palatal aspect and close everything very first intention. But independently on the type of papilla preservation approach, the problem is always to prevent the collapse of the supracrestal soft tissue that is closed once the defect is open, once the root planing is done, once the ADTA application is made, is open again and replaced in its original position. It must not collapse. The idea was not to make any vertical releasing incision anymore, and to extend the mesial distal dimension of our flap to the adjacent healthy teeth. If you consider the adjacent papilla, and if you consider that at the level of the adjacent papilla with respect to the defect, we make submarginal incision in order to create a split thickness papilla at the buccal flap, there is a remaining anatomic papilla that can be disepitalized. And since from the oblique incision to the tip of the anatomic disepitalized papilla there is always a 2-3 millimeter distance, we can coronally advance our flap, so get our flap free from muscles in order to make this papilla coronally advance 2-3 millimeters. This papilla coronally advance about 2-3 millimeters and be fixed above the anatomic. And the same is on the other side. This papilla split thickness will be positioned on this disepitalized anatomic papilla 2-3 millimeters more coronal, and the same is for this papilla that can be coronally advanced and displaced above the disepitalized anatomic papilla for 2-3 millimeters. And now, since this is an envelope type of flap, so the whole papilla belongs to the same flap, what does happen to this papilla that is comprised between 4 papilla that are anchored in more coronal position? What does happen to this papilla that is anchored to the same flap that are displaced more coronal above vascular bed in a more coronal position? Obviously, the position of the last split thickness papilla, that one covering the defect, does not depend on the bone crest, but it depends only, does not depend on the material you place inside the defect, but depends only on the most coronal position of the anatomic disepitalized adjacent papilla. So this papilla is closed exactly at the same level of the tip of the adjacent anatomic disepithelialized papilla because it belongs to the same flap, and this flap has been anchored corner 1, 2, 3, 4 points. And the only area in which there is no direct closure is where the suprabonic component of the defect is closed by first intention. So if you look at these sites, more specifically, you can achieve exactly the same outcome we are used to achieving in mucogingival surgery. So by coronally advancing the flap, the soft tissue margin is displaced 1 millimeter more corner with respect to the cemento-enamel junction. Obviously, we are speaking about the cemento-enamel junction of the healthy tooth and the place where the split thickness papilla on one side and the supracrestal soft tissue on the other side are closing each other is exactly at the same level, more corner than the soft tissue margin at the same level of the adjacent anatomic disepithelialized papilla. And this is completely independent on what you place in the intrabony component, even if you don't place anything. In other terms, is no more the membrane, is not more the biomaterials that we place inside the defect that sustain the supracrestal soft tissue in this position, but the soft tissue maintain this position independently on the presence of biomaterials because they are linked at the adjacent anatomic disepithelialized papilla since they belong to the same flap, which are anchored in more corner position in 4 different levels with respect to the only one that must close above the intrabony component of the defect. And this is exactly the way we tried to compare in some way the advantage of this procedure with respect to the minimally invasive approach. You know that minimally invasive means an advantage for the patient, but the most important concept of being minimally invasive is if there is a true advantage in the terms of final outcome. Minimally invasive means that you only open one papilla, that is that one of the defect, and you only move the supracrestal soft tissue in the palatal aspect and get it free from the granulation tissue without any opening of the adjacent teeth and adjacent papilla. But you can see from this picture that I want to share with you another time what happens even if you open one papilla. Look, this papilla at the beginning was almost at the same level or more corner than the level of the papilla of the adjacent teeth, yes? And immediately once you open it, split thickness, in the so-called simplified papilla preservation approach, you see that this papilla has the tendency to shrink immediately because once you open the buccal flap, it always shrinks, especially if there is a frenulum, especially if the thickness of the flap, but even in this case, that is a very good keratinized flap with a good amount of keratinized tissue, immediately after opening this papilla has the tendency to shrink in apical direction. So it's not true that it stays there. Once it is open, it's positioned more apical. And until this tissue is maintained in this position, yes, this is stable. It's not collapsing. But we have also to get rid of the granulation tissue filling the intrabony component of the defect. And once we get rid of the intrabony component, soft tissue, filling the intrabony component of the defect, also the supracrestal soft tissue has the tendency to collapse inside the defect, even if I open only one space. So if I am really minimally invasive. And once they have to be close, they are much more apically with respect to the original position. So we lose height, even if we open one papilla. So I think that the minimally invasive approach, it's something that is very, very nice for the patient, obviously, because you open one papilla, you close, you open, you close, and immediately you close back. So there is no invasivity in the surgical procedure, but it's not, per definition, a way to prevent collapse, to prevent shrinkage. Because even one papilla is open and the other two papilla is completely firm, there is the tendency of the papilla buccal to shrink and the supracrestal soft tissue to collapse. Yes? The only way to prevent this is try not to open at all, not to turn the papilla towards the buccal aspect, but try to make only one flap. Namely, to use a single flap approach, yes, to open only the buccal flap and try to remove the granulation tissue from the defect without elevating the supracrestal soft tissue in the palatal direction. This is what Sandro Cortellini called mist modify, which is the minimally invasive procedure that is being modified because we open only one flap. And this is the only way, if you don't separate this tissue, if you don't elevate this tissue, that otherwise will collapse immediately. And so there is no advantage because you don't prevent collapse. So the only way to prevent collapse is not to open one of the two flaps, but when you can make only one flap opening. When can you open only the buccal flap or only the palatal flap? Only obviously when there is no defect on the other side. And so the mist modify, according to me, is a very nice procedure, but has very limited indication because most of the defects, unfortunately, are very deep. So in order to get access to the deepest portion, it is not enough to open one papilla and to have good visibility of the root surface that you have to treat. And most of the defects, even if they are not deep, have a supra-bony component. What does it mean? Do you remember what is the supra-bony component? Is some bone loss also at the healthy tooth. And so the defect starts more apically. And if you only open this papilla and you don't open the other flap, you are not able to have a good control of the root planing on the supra-bony component of the defect. And so you are not sure, or you are not so sure as you have once you open to make the root planing procedure, the ADTA application, the isolation of the defect as you can make once you open. So in my mind, yes, if I can, I will use the minimally invasive approach, modify, so only one flap is open, just open one papilla, get access, but in the once I need to open the flap because the defect is very deep or there is quite a big supra-bony component, I cannot make a minimally invasive approach. Because of this reason, because once you make it and you try to close it, it's much more apical. And so you have to do something to compensate for the tendency of the soft tissue to collapse. And what is it? We just saw it. You have to open also the adjacent papilla, yes, split thickness, submarginal, and since I am able to anchor my split thickness papilla in more corner position, my split thickness papilla in more corner position, you can see that in the same case, now where the two simplified papilla and the supracrestal soft tissue close is no more in apical direction, but is exactly the same level of the adjacent desepithelialized papilla. So by coronally advancing the flap and by anchoring the flap to the adjacent desepithelialized anatomic papilla, you compensate the tendency of the soft tissue to collapse. That is something that can occur even if you open only one papilla, even if you are less invasive. So invasivity means, Yes, I open the flap. Yes, I get it rid from muscles. Yes, so I'm more minimally invasive. But in this case, the supracrestal soft tissue and the split thickness papilla close each other in the most conal position, even without the use of any biomaterials, and does not collapse inside the defect. That is something that happens, as I'll show you, in the same clinical case, if you only open one papilla and you turn the supracrestal soft tissue on the other side in order to get access to the defect. How to coronally advance the flap? We have already learned it. The first time we met, I think, we spoke about how to coronally advance the flap, a flap for multiple gingival recession. And we said that there is one very frequent approach, which is the lateral approach, in which all submarginal incisions are direct towards a midline, or towards an imaginary line passing through the mid-buccal surface of the canine. And this was called lateral approach. But there is also a frontal approach that is only used to treat gingival recession from lateral to lateral, and this is used by making submarginal incision at the level of the adjacent papilla, and in this case, these submarginal incisions are direct towards the midline, passing through the interincisors papilla. So two approaches that you have to select to treat multiple gingival recession according to where you have gingival recession. If you have gingival recession from 1 to 6, you have to select the lateral approach, yes. All submarginal incision convergent to the canine. When you have only recession in the 4 incisors, no recession in the canine, no in the premolar, no in the molar, you can make the frontal approach from 3 to 3 with all submarginal incision direct towards the midline. The same approach, the same flap design is applied exactly the same for the treatment of vertically bony defect. If you look at this picture and if you look at the following picture, you can see that there is only one difference, and this is the area of the defect. But nothing changed with respect to the flap design at the level of the adjacent papilla to be desepithelialized. So the general rule of thumb is that for all defects that are located distal to the lateral, or mesial to the canine, or distal to the canine, or mesial to the premolar, so they belong to the lateral aspect, we have to perform the lateral approach. So we open a flap from 1 to 6, 1 to 7, the all incision at the level of the space neighboring the defect are directed towards a midline passing through the canine. The remaining papilla are desepithelialized. The flap is get free from muscles, coronally advanced. While if the defect is located mesial to the lateral or between the two central, so it means that we are treating the frontal area, the flap is from 3 to 3, and all incision at the level of the adjacent papilla is directed towards the midline passing through the interincisors papilla. Now you have the opportunity to anchor your flap, which is an envelope flap, to 1, 2, 3, 1, 2, 3, 4 desepithelialized papilla in a more conal position, and at the same time where the supracrestal soft tissue close with the split thickness surgical papilla is exactly at the same level of the most conal extension of the adjacent anatomic desepithelialized papilla. And if you look at more carefully these two cases, it's very interesting because they are very, very similar from one side, but also different defect. If you look at the defect and the intrabony component of the defect, they are exactly the same. So this is the bone crest, this is the bottom, this is the bone crest, this is the bottom, and they are mainly made of one wall defect. But between the two defects, there is enormous difference. It is the distance between the bone crest of the adjacent tooth to the cement enamel junction. You see, this defect is only vertical defect. There is no suprabony component at all. This defect has enormous amount of suprabony. So from a regeneration point of view, they have the same potentiality, exactly the same, because the regeneration depends on the intrabony component. So they are exactly the same. What is extremely difficult, what is extremely different is the risk for gingival recession, the risk of collapse. Here, the risk of collapse is nothing, because there is immediately the bone crest. So this is a case that is perfect also for the minimally invasive approach, you know, because the bone crest is there. You just open the papilla. You don't have to open the buccal flap, the palatal flap, or minimally, but the bone crest is so close that prevents shrinkage. Do you understand? But what about here? If you open only one papilla, and if you open the other papilla, just to make root planing on these two surfaces, there is a high risk of collapse. And so the aesthetic outcome is completely different. While if you use the mucogingival approach, and that's the main advantage, where does the chew tissue that is closing first in tension above the intrabony component of the defect is exactly in the same position, because this does not depend on the position of the bone crest. Do you understand the concept? They depends only on the position of the adjacent disepithelialized anatomic papillae. So where these two tissues close each other is not influenced by the biomaterial, so you cannot use any biomaterials because you don't need any biomaterials to sustain this, and it does not depend where is the bone crest. The bone crest is here, the bone crest is there. And independently on where is the bone crest, independently if you don't or if you use some bone filler materials, they remain in this position because they are anchored to the adjacent four sites, four adjacent anatomic papilla that sustain your flap in the coronal position and prevent your flap from shrinkage. So this is, according to me, the great advantage of the mucogingival approach to the treatment of vertically bony defect. That is, every single time you have deep defect. Deep defect means that in order to make the root planing completely, you have to open. And since you have to open, there is the tendency to shrink. Since there is the tendency to shrink, you have to do something to compensate for the tendency of the soft tissue to shrink. And this is by coronally advancing the flap. What is the last modification I did? I already told you this morning. I not only make the coronal advancement of the flap, but I also want to improve the stability of what? Of what? Of the buccal flap. That is the problem. Because the buccal flap is a problem once you don't have bone, or once you have a suprabony component. In this case, the flap, if it's not so keratinized, if it's not so thick, can shrink, even if you link to four papillae. And so how can you do in mucogingival surgery to prevent shrinkage, to prevent the tendency of the coronally advanced flap to go back to its original position? You add a connective tissue graft. So now it is the time to understand why my last modification, which is not really the last, I have to tell you a further modification, but I will tell you in a moment, is the use of the coronally advanced flap plus the use of the connective tissue graft in all situations when there is lack of the buccal bone, yes, and all the situation where there is a suprabony component of the defect. In this way, I can prevent shrinkage, collapse, independently on the quality of the buccal flap. So this is, generally speaking, the approach which was described in 2008. At the time, it was with no graft, only with a coronally advanced flap to prevent gingival recession in the treatment of vertically bony defect. And in this first study, we made some measurement starting from the time of the first visit, not after non-surgical phase, at the time of the first visit. So we measured the distance, we make the radiograph, there was a deep defect to be treated, vertically bony defect, all defects were localized in the aesthetic areas. So before making any non-surgical phase, we measured the distance between the occlusal margin and the soft tissue margin of the two teeth neighboring the intrabony defect, and we also measured the distance between the occlusal margin and the tip of the papilla. Then we start the non-surgical phase, and as you know, the non-surgical phase was done with the use of different type of ultrasonic points, and 4 weeks later, which was the time of the surgery, we repeat the same measurement, and you can see that there is almost no gingival recession, only some minor loss of the tip of the papilla. Why? Because unlucky, this papilla has a tip and not a isthmus. Because if it was a isthmus, the shrinkage would have been even less. Now there is the surgery that we will see much more in details later and tomorrow. It's a coronally advanced flap, desepithelize of the anatomic papilla, and this is done at the buccal aspect and also in the palatal aspect. It's a flap that is done to expose completely the most apical extension of the defect with, let's say, very bevel incision at the level of the papilla close to the defect, which are left in place. But again, this is something that we are going to see in the movie. And now only one material, biomaterial, is used to promote regeneration, and this is the amelogenins. The amelogenins is used in this procedure, and it's something that I always use in my regenerative procedure, because we have to remember that we don't want to promote only bone. We want to promote bone and periodontal regeneration. And the only material we have in the market available that is done to promote new connective tissue attachment formation, new cementum formation, and new bone formation is the amelogenins. These amelogenins are placed in contact with the root after ADTA application, after removal of the ADTA from the dentin tubuli. So now we have the collagen content of the dentin tubuli completely available for the interaction with the blood clot. This gel, which is applied above the root, has the capability to deposit this protein, which must remain in contact with the bone and the root. Once the gel has deposited the protein, the gel must go away, because the cells capable, once they get in contact to the amelogenins, to be transformed in cementoblast, fibroblast, and osteoblast, are not contained in the gel, but are in the blood clot. So if the gel is too stable, it prevents the space to be occupied by blood clot. So the gel must stay, let's say, 1 minute, locally applied, in order to leave the gel the time to deposit the protein, and then you don't have to care about the gel, and you have to close. To close by desepithelize the adjacent papilla, coronally advance the flap, anchoring the flap to the adjacent papilla, and make the closure of the supracrestal connective tissue with the split thickness papilla at the buccal aspect exactly at the same level. Then the measurements were made at 1 month, 6 months, and 12 months. And you see in this case, let's say, one of the first study that has been published in the literature in which we can start to speak about no increase in gingival recession. But not only at the level of the adjacent teeth, which are exactly in the same position, but also at the level of the papilla, which can also improve with time. Why? Because it's the bone. That by improving the bone, also the soft tissue can improve with time if you don't lose any amount of interdental soft tissue. So this is the outcome of the study. And if you compare the baseline, remember the baseline is the time of the first visit. With 12 months after the surgery, you have exactly the same numbers. 11.1, 11.2, 10.9, 10.8, 6.9, 7.0. So exactly the same. What does it mean? That we were able to maintain the soft tissue position we met at the time of the first visit exactly the same 1 year after the surgery. It means that gingival recession was 0. And this not only at the level of the two teeth neighboring the defect, but also at the level of the interdental papilla. And by making 0 gingival recession, you leave more space for the blood clot to form and for this blood clot to become new bone, new periodontal ligament, and new periodontal apparatus. And so also the response of the bone, even if we did not place any bone filler materials, was really very impressive because there was a complete regeneration of this defect in most of the case, even with no biofiller material. So this was bone for sure. It was not bone filler material together with any bone. And this is the outcome of the study. And what you have to look at is the changes we had 1 year after the surgery. 0 gingival recession, no gingival recession at all. Clinical attachment level gain 5.6, almost 6, let's say. And the whole reduction of pocket was clinical attachment level gain. And this is very important study because once you don't have gingival recession, it is possible that all reduction of the pocket is by improving the level, the consistency of the periodontal and bone tissue. And if you look how much bone was gained radiologically, this was exactly 1 millimeter less than clinical attachment level gain. And in other terms, this is the maximum you can achieve if you consider then from the bone level to the attachment level, there is at least 1 millimeter of connective tissue attachment. So this technique can be applied also for the treatment of multiple defects. Obviously, when you speak about multiple defects, it must not be defect, mesial and distal to the same interproximal area, because this is an horizontal bone defect. Even in the same teeth. This is not in the same teeth. We have, for example, a defect mesial and distal on the same teeth, but yes, but we have bone picks on the two adjacent teeth, yes? And also another defect is here, but we have a bone picks here. What you need is a bone pick, and what you need is adjacent, anatomic papilla, completely healthy. And here, there is a completely healthy situation here. 2 central incisors. The bone is perfect. Here, you have a completely healthy situation. Here, distal, between the lateral and the canal, completely healthy. So we make an envelope type of flap, and of 1, 2, 3, 4, 5 papilla, yes. This is healthy, so it is disepithelialized, yes. This is healthy, so it is disepithelialized, yes. This is healthy, so it is disepithelialized. This is a defect. This is a double defect. And so this is elevated. But then you apply, you coolly advance the flap, you make exactly the same procedure, and you can see this is the baseline, this is the 3-month, this is the 6-month, this is the 1-year outcome, in which you can see that from the beginning to the end, 1 year later, there is an improvement in the soft tissue together with a complete healing of the bony defect. So this was why our tendency from that time, 2008, was not to use biomaterials anymore, but to invest as much as possible in the stability of the soft tissue. Because if we are able to give stability to the soft tissue, we are also able to improve the quality of the bone heal.